I'm showing here the recommendations and the positive and negative recommendations. This is 1A plus. This is the positive recommendations. This is the procedure which effectiveness demonstrated in various RCTs of the good quality, and the benefits clearly outweigh the risk and burdens. This is A plus recommendation. There is a positive recommendations to do the procedure. You should do the procedure, such type of procedure, like fluoroscopic guidance, SI joint steroid injection for the sacroiliitis. It has a 1A plus recommendations. 1B plus, it is also a positive recommendation. As interventionalist, you can do it. One RCT or more RCTs with methodologic weakness demonstrate effectiveness. The benefits clearly outweigh risk and burdens. And last positive recommendation, one or more RCTs with the methodologic weakness demonstrate effectiveness. Benefits closely balanced with the risk and burdens. And this is 2B plus minus recommendations. This can be considered for your practice, preferably study related. Multiple RCTs with methodologic weakness yield contradictory results, better or worse than control treatment. Benefit is closely balanced with the risk and burdens. And 2C plus, that is, it can be considered for your practice, but preferably it is study related, and effectiveness only demonstrated in the observational studies only. And the last one is the 0 recommendation. There is no literature or there are case reports available, but these are insufficient to suggest effectiveness and or safety. These treatments should only be applied in relation to studies only. And these are the negative recommendations. You should not do this type of procedures. So 2C minus, that is observational studies indicate no or too short life effectiveness, given that there is no positive clinical effect. Risk or burdens outweigh the benefit. And 2B minus, this is the one or more RCTC methodologic weakness or large observational studies that do not indicate any superiority to the control treatment. Okay, and risk and burdens outweigh the benefit. And last one is the 2A minus. You should not never do it. RCT of the good quality which does not exhibit any clinical effect, given that there is no positive clinical effect. Risk and burdens outweigh the benefit. Like your DRG for the conventional RF of the DRG. I'm showing next few slides are available evidence in different clinical scenarios. From neck to lumbosacral spine, I will go. For the cervical radicular pain, one of important pain condition, the pathology in the cervical vertebra, and the pain is radiations according to the dermatome. It may be usually 5, 6, 7. Okay. So what is the intervention? Intervention is interlaminar epidural corticosteroid administration. I think some of interventionists do this procedure very frequently for the cervical radicular pain. Its level of evidence.
Sorry, you have only 3 minutes more.
Okay. I'm going very fast. Okay. So it has the level of evidence is 2B plus. What I have shown behind, actually, how the level of evidence is identified. It has the 2B plus. So next one is the cervical DRG RF. Its evidence is radio frequency treatment adjacent to the DRG is 2B plus. If it is pulse radio frequency treatment adjacent to DRG, it is 1B plus recommendation. It's a very good recommendations. And cervical facets, it has, you can see here cervical medial branch RF, radio frequency medial branch 2C plus recommendation. But interarticular, it should be study related only. You should not do cervical facet interarticular injections. So then next one is the thoracic. Thoracic facet pain is a very important pain condition. This is the pain pain map of the thoracic facet pain, and you can go for the thoracic radiofrequency medial branch block. It has a 2C plus. It's a positive recommendation. You can do it. And thoracic radicular pain, you see here, it has the RF, DRG 2C plus, and the pulse also have the 2C plus recommendations. So you can do it. And lumbar radicular pain, interlaminar epidural steroid injections. It's a very common practice in all over the world. Interventional pain specialist or physiatrist or orthopedician, a lot of people, they are doing this thing. It has a 2B plus minus recommendation actually. Better to avoid. Transforaminal corticosteroid incontinent herniated disc. It has a 2B plus plus recommendation. But in the non-content, there is a ruptured disc, there is the negative recommendation, mind you. Radiofrequency DRG, pulse radiofrequency DRG is the 2C plus. I think due to shortage of time, I could not see or explain the procedures very nicely, but I'm just showing. Adhesiolysis epiduroscopy. This is usually for the failed back surgery syndrome. We use this one. Level of evidence is 2B plus minus. This is the spinal cord stimulation. Is the spinal cord stimulator is the pacemaker of spine like this. It has a level of evidence is 2A plus. It is very costly. It is for the failed back surgery syndrome only. Pain originating from the lumbar facet joints. You see here somebody doing the interarticular joint injections. It has a 2B plus minus recommendation, but RF it is 1B plus recommendations. You can do it. For sacroiliac joints, it has a 1B plus recommendations. For the interarticular steroid injections, it works very nice. And you have also the sacroiliac joint RF. This is the recommendations. And for the discogenic pain, this IDET, it has also the 2B plus minus. And for the ramus communicans for RF is 2B plus minus. And I'm coming to the last of the part, that is the cancer pain. Cancer pain, interventions for the cancer pain when it is needed actually. Our earlier cancer pain specialist, he was telling about the conservative part of the treatment, but there is interventional part of the, some patients need actually at that time. So pain can be refractory to pharmacological treatment. So on that time, it needs the interventions. So intolerable side effects of the pharmacology, he's giving the drugs, but the patient is became drowsy or some side effects like morphines and other respiratory depressions, a lot of things. So when this is the situation, so you can do the interventions. For the fourth consecutive step following the World Health Organization's pain treatment ladder, this is the fourth step actually. Up to third step you can do very well as oncologist. So in the fourth step, yes, you have mentioned it very nicely. So in the fourth steps we can help you actually very nicely. And evidence for the epidural and the intrathecal medications, you see intrathecal medications delivery have 2B plus, epidural medications delivery has the 2C plus recommendations. Podotomy, it has a 2C plus, and celiac plaques, it has a 2A plus positive recommendations. And for the splanchnic nerve block, it is for actually abdominal cancer actually. These are the treatments policy from the intervention of pain management. Level of evidence is 2B plus here. And neurolytic plexus blocks for the pelvic organs pathology, like pelvic organs, bladder cancer or prostate cancers or female for the visceral cancer, uterine cancer. It has a 2C plus recommendations. Vertebroplasty sometimes needed because of the secondary mass in the vertebra, and there is a compression fracture of the vertebra. It's a very painful situation. It has a 2B plus. So as interventions, my presentation is only for the who are involved with the intervention actually, not for all actually. Those who are doing the practice in there. So what should do, what should not do, that is very important because some have you may know a procedure, but you should not do because there is a negative recommendation. This is my message. and some has the very positive recommendation. You should do. Okay, so like this. And it is another kyphoplasty also is for the compression fracture of the vertebra. And thank you all.
Thank you, Dr. Sardar. Dear learned audience, we are having the shortage of time. So, thanks Professor Rashid, Professor Baki, and Dr. Sardar. If anybody audience is interested or ask about query their presentation, please talk after the session. Personally, they can contact with them. And thank you for they have discussed both of these they have discussed elaborately. Though it is a multidisciplinary subject, so I ask Professor Senior Professor Khalilur Rahman to conclude the session. Thank you.